Well, aloha, everybody, and welcome to the 2021 Hawaii Veterans Summit. My name is Jackie Boland. I'm the Community Outreach Director for AARP Hawaii, and it's my pleasure to welcome you here today on behalf of our sponsors, the Hawaii Office of Veterans Services, the Hawaii Veterans Foundation, and AARP Hawaii. Before we go into the program, I just want to let you know that there is one more event scheduled as part of the Veterans Summit. It's happening next Tuesday, same time, same link, with former POW Jessica Lynch, and we hope you'll join us for that session. If you're new to Zoom, I just want to let you know that we'll only be using the chat today for technical issues. If you have a question for one of the speakers, you can put it in the Q&A tab, and Dr. Brown will be fielding your question to our panelists. We also won't be using the raise hand function. We have turned on the live transcript function because we did have a request for that. However, if you don't like it, you can turn it on, just click on that live CC transcript button at the bottom of your screen and disable the transcript. These folks are going to be our distinguished panel today, but before we hear from them, I'd like to have you hear from Dr. David Brown, who will be talking to you a little bit about some of the behavioral health issues that veterans and their families do face. Dr. Brown, take it away.
Hey, thanks so much. I just lost myself. Okay, am I there?
You are there. And also, okay. I did want to mention, if you're watching on Facebook and you have a question, do feel free to put it in the comments section on Facebook, and I'd be happy to get that question over to Dr. Brown. Thank you. Go ahead.
Okay, thank you so much. First of all, I'd like to thank the wonderful folks at AARP for partnering with the Hawaii Veterans Summit crew. On behalf of Carlos Santana and myself, it's been a pleasure to work with you all, in particular, Miss Vicky Franco and Jackie Boland. So what I'm going to do before we get into the panel is to set the stage for everyone to really understand what we're looking at with behavioral health, and in particular looking at behavioral health from the DoD active duty VA side of the house, so to speak. So let's go back. The presumption is that the audience today are veterans, are family members of veterans, or children of veterans, or transitioning active duty. So go back when you were in uniform, be that 5 years ago, 10, 15, 20, 30, 40 years ago. What I'm going to share is from the last 30 years that I've been associated with Department of Defense. And this is to help to set the stage for some of the complications that you would have pre-electronic record. The electronic record Alta came out in 2006. I remember I was in Japan at the time when that rolled out. Prior to that, when I was in Germany, when I was in Bosnia, when I was in Hawaii, Colorado, in the field multiple times, if you went in to see someone at behavioral health, after 5 years, your record would be shredded and there would be no record of your services that were rendered to you, any psychological testing, anything such as that, unless you received medication from a psychiatrist. That would go to your medical record. That would follow you. So if you, from a deployment in East Timor, Kosovo, Somalia, the first Gulf War, ever saw behavioral health, or if you ever during a PCS felt a little worked up because of all of the stressors involved with the move, if you had any marital difficulties, if you had anything such as that going on, none of that would be in your record after you left, after a 5-year period. So after you leave and you go to the VA and you want to seek services and say, hey, this is part of my record, you don't have that as something to verify what you had gone through. So I just wanted to set the stage for that, because what we've got today is, instead of having active duty folks talk about the active duty mission, the audience today doesn't have access for the most part to receive care there. You would have potentially services available through the VA, if not the VA, through on island. Now we have Cohen Veterans Network and some other private entities to whom you could seek services. So I just wanted to set the stage for that. And with that said, we'll get into discussing with our panel who are their beneficiaries and how do they access care and what services are available. So without further ado, Jackie, would you bring everyone back on, please?
Sure. So folks, if you want to see just the slide, David, or did you want everybody to turn their camera on?
Just a slide at first, and then what I'll do is I'll speak to a couple things with services, and then I've already seen everyone's slides, so I know that they're going to speak to this. So first of all, I'd just like to say thanks again for my good buddy Andrew Dahlberg. I've known him for over 20 years, and he and I are like Paul McCartney, John Lennon with getting together and doing stuff. So it's always a pleasure to work with Andy. Andy's got a crew from the VA coming on board, and also Miss Covington from Cohen Veterans Network will be speaking today. I'm not going to take thunder from them. I've been speaking enough, but what I do want to mention is, what we will be looking at the full gamut of behavioral health services in terms of anxiety disorders, not just PTSD, traumatic brain injury, but anxiety-based disorders, depression, adjustment disorders, counseling for family, children, a whole host of things that you'll be witnessing today. So without further ado, can we bring everyone on board? This gives everyone a chance to see the four individuals, and then what we'll do is we'll just go ahead and let them introduce themselves, and then I'll pose that first question to Ms. Covington, please. All right, so I see Miss Janet Covington on camera here. Who else do we have?
You've got everybody. You should be able to see everybody.
Okay, so I'm just technically challenged. So everyone's on. It sounds like we got the Brady Bunch or Hollywood Squares type thing. Without further ado, Ms. Covington, would you tell us all who you are, what you represent, and then I'll get into posing a question to you, please.
Sure. My name is Janet Covington, and I'm the clinic director of the Stephen A. Cohen Military Family Clinic at Child and Family Service. It's a wonderful, wonderful new opportunity for our veterans and their families. The clinic opened up in September of last year, and we have been going strong since we opened. Our mission is just to take care of our veterans and take care of the family members.
Wonderful. And if you don't mind, let's go ahead and just get into that first question. How do people access care to you, and to whom do you serve? Who are your beneficiaries?
In terms of who our beneficiaries are, they're veterans and their family members. In particular, it's post 9/11 veterans, but we are open to any veteran who has served at least one day in uniform, regardless of discharge. And that's something that's a little more unique about the Cohen Network, is the fact that we do really work on eliminating barriers to care, of which that was one, how long did you serve and what was your discharge? You can access care through us by calling our phone number, 808-204-4020, and somebody will answer our phone and kind of get an idea of what you're looking for, and then have you set up to work with a clinician. It's really easy to see us.
Wonderful. And I don't want to take thunder from you with your presentation that you've got with regards to services you render. We'll get to that after we speak with the gentleman from the VA. But do you have anything on how Cohen Veterans Network came about? I've known Anthony Hassan, the president and CEO, for years, and he spoke 2 years ago at the convention when we had the Cohen Veterans or the Hawaii Veterans Summit. In fact, you were there, weren't you?
I was, and I knew that Anthony was going to be there, and I actually stalked him because I had heard about the clinic. I was really intrigued about what the clinic offered, and I really wanted to talk to him to learn more about it and to see, what was coming to Hawaii and how we could best, utilize the services. And little did I know at that time that I would be the clinic director, but I obviously have been very, very, very interested in the mission, and I believe that it's we have a place here, that we have a niche, and we're filling gaps and working in partnership, with the VA and with TAMC and with other entities.
And what I had said earlier with setting the stage for having something captured in one's medical record, that is not something that's required to be seen at your clinic. As you said, you need to serve at least one full day, and you're a bona fide beneficiary for your services.
Yeah, and we're a little different too, because family is anybody who the veteran says is family. So they do not have to be in DEERS, they do not have to be necessarily a blood relative. But if a veteran comes to us and says, I have a family member and that person's important to me, can you help? The answer is that yes, we can. And one thing great about, our organization is, you asked how we came about. So about 2 years ago, when Dr. Hassan was here, we started exploring partner organizations, because every Cohen clinic throughout the nation, and there's 20 clinics right now with 4 more in the process of opening this year. But we always partner, with an organization that's local, that has some roots here, that has experience. So Child and Family Service is the partner organization. So, I work, with 2 great organizations, Child and Family Service and with Cohen. Child and Family Service has been in Hawaii for 122 years. And we've been working with families and children and helping military for a very, very long time. So it's a really good fit for us.
And I know for our active duty mission, there are times that our personnel are repurposed more to their primary mission, and that is the active duty folks when they're redeploying. And there are times that our staff from Child and Family Behavioral Health might be repurposed, and the clinics might be shut down to services to an extent, and they are also recipients of your care. So we thank you for that. Those are folks that we wouldn't be able to typically send over to the VA for care. So I think we've got a really nice network here in Hawaii. We're on an island. We've got to take care of one another.
Right, and even with our active duty service members and their families, I mean, it's, we help them as well. So active duty, our doors are open to active duty members and to their family members. And I know a lot of times, there's difficulty for family members, especially to receive services, because there's a shortage of providers, especially in behavioral health. And so, we've been helping a lot of them. And in fact, we're a little bit different from some of the other Cohen clinics on the mainland, because, we have a large percent of our population is, a family member. It's, a spouse, it's their children, and we do a lot of couples work too.
Well, thank you very much for your time. I'll come back to you with a follow-up question here. Let's go to our gentleman.
Thank you.
Okay, if you don't mind, Mr. Dahlberg, Dr. Brian Kelly, and Dr. Scott Masters. Jackie, can you assist me with that?
They're all on camera, David.
Oh, okay, I'm just looking at you now. So I guess they need to speak up so I can so that they'll populate on my.
May I recommend, if you go up to view in the upper right part of your Zoom screen and put it into gallery view, you'll be able to see all of them.
There we go. I'm just not confident on this non-DoD network. Okay, so gentlemen, thank you so much for joining up with us here. And same question posed to you. Well, first of all, let's get to know you. If you don't mind, can we have a go around? Introduce yourselves, who you are, what you do, what makes you tick?
Sure, I can start. My name's Scott Masters. I'm the Deputy Associate Chief of Staff of Mental Health. I'm actually living in Kona now. We have a clinic here in Kona, but was for the last couple of years in Honolulu at our major base. And I guess I could answer the question about who we treat and eligible veterans. It's a little smaller scope than what you just heard. Our primary mission is treating veterans who are eligible based on a criteria set by law. And part of the process of coming into the VA is determining your eligibility, which we're constantly working on to be a more streamlined process so that people can know if they're eligible for services. Just to give you an idea, some of the things that are considered on eligibility would be time served in the military, might be the status of your discharge, whether it was honorable, dishonorable, or one other categories, whether you were in the reserves and deployed during your time in the reserves might make you eligible, whether you have a service connected condition, that's a condition that happened as a result of your service that's been determined by the VA. So there's a number of things kind of that have to be checked to find out if someone's eligible. And in terms of family members, fantastic the work your group is doing with families. We're a little more limited in that we offer family treatments in concert with the veteran, but we aren't able to offer individual or certainly not to minors of a veteran, so we're fairly limited. There are exceptions to that. For instance, we have a caregiver program, and that allows that individual caregiver to receive some treatment within the VA. But for the most part, our mission is more narrow than what you just heard around treatment of the veteran specifically. But I hope that answers the question a little bit different than the much wider and a wonderful scope that Ms. Covington's program has.
Yeah, it does very much so. In full disclosure, I am a patient. I am a customer. I get my medical care. My shoulders all beat up, my knees. I've been dinged up quite a bit. So anytime I need care, I get my care from VA, and I'm very happy with it. And if they can't treat me, they send me to a place near my home here, and I rave about you guys all the time. So, and I partner with you all the time on stuff. So thank you so much for all you do there. Now that is access to care, addressing the access to care question initially and the beneficiary. I know we've got a lot more depth to get into, and we'll get that some more of that depth with Mr. Dahlberg and Dr. Kelly, but we'll get to that in the second half here. We can go back to Ms. Covington and ask, what are the services that you offer? What are your programs that you have?
We offer individual counseling support, and as well as counseling for couples. We do family therapy. We work with children. We have groups that are here as well.
And did you have a slide that you wanted to put up to show that, a one pager or something?
Sure, I could do that.
So I know the VA's got quite a bit to get into.
David, just to jump in here real quick, did you want everybody on camera while she's doing her part, or can they turn off and then you'll call on them when it's their turn?
Sure. Yeah, we'll get back to them after she does her talk on that with the services, because they're going to be getting in a lot of granularity and a lot of depth on there. So yeah, please, if you don't mind. And I should probably do the same, I guess, huh?
Okay, but I think it's one of the good things, like what Scott was saying, is that the VA does a good job with the parameters that they work in, and so we're a good partner because we can fill the gaps that the VA maybe can't fill, and vice versa. And so I really think that having Cohen here is really a good addition to behavioral health support. But this kind of gives you just a little bit of an idea of the clinic. We're located in Mililani, Mauka. So we're very centrally located. It's easy to get to us. Parking is really easy. It's nice to have some place that, we have entities at, Kapolei and Eva, Tripler side, and having us here is really a nice addition. This is, I think that you had asked us a little bit about, our history, and we have a really great history because Stephen A. Cohen, who is a philanthropist, he founded the Cohen Network about 5 years ago. His son joined the Marines as an active duty enlisted Marine, and he was deployed. And when he came back, he told his dad, if you're going to invest in anything, invest in the behavioral health needs of our veterans. And that's when the dad formed the Cohen Veterans Network. And 5 years ago, they had one clinic, and today they have 20, and they're still growing. We continue to see post 9/11, but like I said, we see any veteran that has served at least one day in the military, regardless of discharge. For the mission, It's simple. We want to improve the quality of life for veterans and their families, that we provide accessible care and we work at eliminating barriers. You know, we talked about the barrier of time served and discharge, but, you know, we find also that many times people can't come to therapy because they need childcare. Well, the Cohen Clinic can provide childcare, you know, for the client while they're in session. That's great. And if by some chance you don't have transportation to get here, we'll find transportation. We'll get you to the clinic for your appointment, and we'll also get you back home. So those are two really good benefits that are a little bit different from a lot of other places here. So you had asked David about, you know, what exactly do we help with? And there's a variety of things that we help with. You know, there's our standard things, as you can see, you know, things that are more serious, you know, like severe depressions, PTSD, you know, severe anxiety. But we also help with home life issues. Someone may just have trouble just adjusting to COVID. That's been a big thing this year, you know, to childcare, having to deal with children being home and suddenly your teacher and parent together. But if somebody is troubled for whatever the reason is, it's important that they call us because we can help. You know, we can help a small thing go away. We can help a big thing get smaller. And so we really encourage people to just give us a call regardless of what's going on, and we'll figure out how to take care of you. Now, again, you know, we serve, you know, post 9/11 veterans. We also serve the National Guard and the reserves. And this is really big for me because I worked for a decade, you know, with the Army Reserves and the Air Reserves, and as well as with the Guard. You know, the Army Guard is very close to my heart. And one of the things that I learned while there was that, you know, there were some barriers to care for reservists and guardsmen because, you know, many of them had not been deployed. And so that was one of my interests when I met with Dr. Hassan 2 years ago was, you know, how can you take care of the National Guard and the reserves? And when I found out that they are welcome one day of service and they're eligible, I knew that Cohen was really, really going to be able to help a lot of people. We have right now, we have 5 clinicians that work in the clinic. All of them have military experience in some way, whether they're former, like we have a former Marine that's one of our clinicians. We have an Air Reservist that's one of our clinicians. We have 2 spouses, you know, one whose husband is in, you know, the Navy and another one whose husband's in the Coast Guard. So there's a lot of military competent people that work here. I myself, you know, I'm the kid, you know, of a active duty Army soldier. You know, my dad served about 25 years in the Army, and I was raised as an Army brat, and I think that's still culturally appropriate for me to say. But it's something that I think I'm proud of, you know, that I really learned how to be resilient, you know, as a kid of an Army soldier. My dad deployed to Korea and he deployed to Vietnam, and, you know, my mom stayed home with 4 kids, and it was a challenge. But I think that we're able to feel and to know, you know, a lot of the things that our clients are experiencing. And because of that, I think that our ability to help, you know, is positive. And we're proud of the fact, you know, that most of us here have a history with the military. And that's why we all joined the Cohen Network to work here, is because we could be a part of something that was bigger and better and different. And that's pretty much, you know, what I have to say about what the Cohen Clinic offers. And I have our contact information here. I mean, we're on a variety of social media networks, and that's our address in Mililani. If anybody's familiar with the Gateway Shopping Center leading up to Mililani Mauka, we're right across the street from that. And you can just give us a call, and we're here to help. We have our email there and our website. people can just reach out, and we are more than happy to support you in any way that we can. But I guess in a nutshell, I mean, that is pretty much, you know, what Cohen does. And we can talk about more things later if you have questions, David.
Yeah, thanks much. I mean, oh, am I muted? Okay. Yeah, you hit it out of the park there. So thank you so much, Janet. You know, when I first met Anthony years ago, and you know, there have been many programs that have come and gone, and were wanting to treat active duty or wanting to treat veterans, and didn't really understand the culture. They treat some of our active duty. They might be on 1 med or 2 meds, and they go and they come back a month later and they're on 9 meds. And now they're not serviceable and they have to be medically boarded. And it was questionable what those meds were even appropriate. So some of those groups have come and gone. I think what I really liked was I was a little skeptical initially. And when I met Anthony and he gave the brief, you know, the thought was, is this another group who's coming in to try to take over? But, you know, time prior to coming out here, when I was at Office Secretary of Defense, when we'd have the Joint Chiefs of Staff meeting, you'd go over and you'd have the blessing to see Admiral Mullins. Admiral Mullins is on the board with Anthony, as are a number of other GOs and flag officers. So I really like when we spoke a few years ago about the fact that this is an entity who's trying to take over from active duty or from the VA. It's how do they partner and see, you know, we bridge gaps, but we don't want to have people fall in some of those areas where those Guard and Reserve folk who are in a peculiar situation that maybe they can't care for whatever reason, or those people who didn't have service-connected disabilities, as Dr. Masters had mentioned. And, you know, what do we do for those folks? So I think it's a really nice compliment. I don't see this being some contentious relationship of, you know, DOD, VA, and our private entities fighting and bickering over turf, more so complementing and working with one another. So I thank you so much for that very nice scope of services and programs and things that you have to serve or have to offer. Is there anything else you'd like to say before we shift over to our gentlemen from the VA who are going to bring us home with some of their stuff?
Sure. Well, I mean, I think you're right about, you know, it being a good partnership. I mean, just from us being here since September of last year, I mean, we've engaged quite a bit with active duty and with at the VA as well as with the Guard, and we've been received very positively and very graciously, and we are hoping to continue to grow this relationship and to really see how we could help each other out, because we offer something that's a little bit different. And I think that little bit of difference is really going to make a big difference in the lives of a lot of our veterans and their families. Yeah,
and I cover, you know, more than just Hawaii. I'm seeing some benefit from Anchorage and our folks in Fairbanks, and I know there aren't services set up yet in Korea, but Cohen also has some telebehavioral health supports. I'm also looking at the markets in Sacramento and San Diego and other places, and again, it's just good to know what's out there in the network. I know in active duty, all the care I received was from active duty, and I didn't stray outside the parameters of the base or the post that I was at. I know some people do. Once I got out, I followed single file line as a good soldier right into the VA to get killed. But I know there are some people who can't follow that course. So again, I thank you so much for helping to complement and serve our men and women who have served. And, you know, as you had stated, the family members, the children, my daughter would never refer to herself as a brat, but that is very relevant. And it's a badge of courage. You know, I love it who proudly put their hand up and say, I am an Army brat or a Navy or Air Force Marine. So thanks so much for what you do and for taking care of our good folks up north here on Oahu. And without further ado, I'm going to shift over to our 3 gentlemen with the VA.
Great. This is Scott Masters again, and maybe we can bring up the slides that describe our VA services and some of the range. Thank you, Brian. Good. We can go to the next slide.
And I'll go ahead and back out and let you do your thing, okay?
Okay. Thank you, David. I guess I wanted to first give a idea of the geographical scope of services that we provide, and that is by far the greatest of any VA in the country, since we cover the Pacific Ocean. So we'll start at Oahu. On Oahu, we're going to have 3 different sites of care. Our main site, called our Ambulatory Care Clinic, is where a lot of our specialists, our primary care, and our specialty mental health programs are located. And that's in the VA next to the Army, the Tripler Army Medical Center. We also have smaller clinics in the VA. We call them CBOCs, which are community-based outpatient clinics. And these are much smaller than the large clinic located next to Tripler, but provide really high quality care. One of ours is the Leeward Clinic, which is out in Kapolei, and we are very proud to be announcing that we are opening a new clinic on the windward side of Oahu, beginning to see patients in October. So that's being completed as we speak. With the support of our wonderful congressional delegation that have wanted to expand the VA in various areas. So you can see on the outer islands, we also have a clinic on Kauai, Maui, Hilo, Kailua Kona, and a freestanding community-based outpatient clinic on American Samoa, a very large one on Guam. And then we have 3 smaller clinics, which we partner with a community care provider that's already established in a community, and base staff or fly staff in to be sure that we're covering the Saipan or CNMI islands. And then we do the same with Molokai and Lanai Clinic, where we have clinicians either based within the healthcare system there or come in on a regular basis. So it's quite a big range of several thousand miles, of course. Okay, next slide. So this is the places we offer the treatment. Now I wanted to talk about what the services we do offer, and it's quite a range. So I'll start by saying we cover the what we call the major mental illnesses, but also what I might call the stuff of everyday life that bother veterans. In the same way that Ms. Covington was talking about the range they serve, we do the same. One access to mental health service that's becoming more and more common is a person in mental health that's actually based in a primary care clinic. And we call that PCMHI, primary care mental health integrated care, so that these might be 3 or 4 visits with a psychologist or a social worker or a mental health prescriber of a particular problem a veteran is having. They may not want to go fully into mental health treatment. They may want to use the services with either without that stigma, associated stigma with it, or perhaps their problems can be solved very easily in the 3 sessions. We're expanding that to our outer islands. It's something that integrated team was available in Oahu, but we're now expanding that to our other smaller community-based clinics as well. So that's one major way people get services within the VA for short-term mental health treatment. We certainly provide a range of assessments for PTSD, depression, anxiety, and many other conditions that might have developed during service, or might have developed after service, or might have developed before service and been exacerbated by service. So a whole range of experiences that veterans come with. We want to be sure that he or she gets that proper assessment. And so we have a very large suicide prevention team that with recent expansion to Guam and Hilo with on-site staff, we're doing very sophisticated work in identifying patients who might be at risk of suicide and having outreach to them early on, and also the training of our staff in identifying and screening for either behaviors or statements that might suggest a veteran as at risk of ending their own life. We have same-day walk-in services at all of our sites for mental health care. So they can either get a phone assessment or by video or in person. We think that's very important to be available when the veteran is hurting and not to have an appointment that's many days or weeks ahead when someone's really struggling with a mental health or emotional issue. We're very proud of our specialized treatments. We do a lot of what's called evidence-based therapies, which I think is just a fancy name for a therapy that's been developed over time and studied well and is proven to work for most veterans for the condition that we treat it for. As some of the common treatments you may have heard about are prolonged exposure, cognitive processing therapy are two examples for PTSD that we offer, but there's also a range of cognitive behavioral therapies we offer for depression, insomnia, and many other conditions. We do couples therapy and relationship repair. Relationships can sometimes be have collateral damage from a veteran who's been through a lot, and that can be expressed within a relationship, and that includes programs for interpersonal violence prevention and reparations after that. We have a residential care program for PTSD. That's a 6 to 8 week program where a veteran lives at the site to get intensive treatment for service-connected PTSD. We have transitional work programs and rehab programs I'll talk about in a little more detail in a moment. And we have case management for seriously mentally ill in Hilo and Guam, specialized programs there. Next slide. And just to follow up on a few others, we're going to be hearing a lot about our homeless program, extensive program here in Hawaii that's extraordinarily successful. But we also want to be sure that we offer assessments and treatment for military sexual assault in partnership with our vet centers who do an excellent job in this area. In geriatric psychiatry, we can't forget substance use treatment programs in a range of services from residential through intensive, through outpatient visits and 12-step facilitation. We have this wonderful program for veterans who are enrolled in college, where we have psychologists based at the college where they can provide therapy and counseling to make sure someone has a good educational experience. And finally, some specialized programs such as a program called dialectical behavioral therapy. These are for veterans that struggle with self-injurious behaviors or chronic suicidal behaviors, a year-long program that's shown to reduce those behaviors and offer significant relief, just to give you an idea of some of the range of programs. Next slide. That brings us to how we offer. We're very proud in the last year to have developed a range of very convenient ways to offer therapy. We still offer the traditional face-to-face meetings, but that's a minority of our visits over the last year, significant minority. We're beginning to increase that again at several of our sites as it appears to be safer to do so. But what really exploded in the VA in the last year was video into the veteran's home. So I'm sure you've seen the commercials on TV, particularly at the beginning of the COVID pandemic, where systems shifted very quickly to offering telehealth into the home. The VA was already doing this for about 8 years prior, but we really amped up, and now about 36% of our visits in mental health are offered onto the patient in their computer, their tablet, or their smartphone, either at a confidential place at work or into their home. And we hope to continue that at that percentage or even higher as COVID gets more fully under control. We also do some video into the different smaller clinics from our home base at the ACC for specialist care. We're using the phone when we need to, although we have some limitations in therapy. We don't think it's quite as effective as the video, where we've shown the video to be as effective as face-to-face. But we continue to use that when we need to do it. And then we get out in the community. There's case management out in the field. You'll be hearing a lot of that work being done with the homeless group, homeless treatment group that's going to be speaking, and as I mentioned, on college campuses. So it's a mix of going where the veteran is, or going where the veteran's family are, and the veteran coming to us, and a whole lot of telehealth in between. Next slide. I'd like to just spend a couple slides on highlighting a program that's near and dear to my heart. Before the VA, I specialized in treating some of the more serious mental illnesses, such as schizophrenia and bipolar disorder. And we have a quite successful psychosocial rehabilitation recovery center at the VA, which is also beginning to expand into the more rural sites. I'd like to describe that experience for you. The next slide. So this is a program that provides intensive outpatient mental health services to help some of our most vulnerable and needy veterans, often veterans that are recovering from severe mental illness. And the idea is to get them to a state where they can regain independence, life purpose, direction, and if it is their goal to work in some capacity, to find the value in the work through a transitional work program when the psychosocial rehabilitation has been completed. Next slide. Good. So this would be a typical veteran in our program, is around 50 years old. This veteran has struggled with significant mental health symptoms, probably for decades, and that could include PTSD, bipolar, psychosis, where they hear voices or see things that other people can't see. So really struggling with the concepts of reality impairment. They are often unable to secure or hold down work. They're often very alone, alienated from family and friends. It's not uncommon for them to have a history or current problems with substance use that's have them drifted down, and further alienation from others. Often they're service connected. They've served honorably. They're at risk, as you can imagine, with the things I just mentioned, of homelessness. It's hard to pay your rent when you don't have those basics in your life that I mentioned. And often this group has a history of hospitalizations for suicidal risk or attempts. So a population very much in need. So how does a program like this work? They're assigned advisor to design a recovery plan. That's an individual plan for them to find out what areas need to come up, what areas need to be fixed in a way, and what are the values the person has, where do they want to grow into. From that, the veteran would pick a range of classes to learn coping, regaining independence, symptom management, the role of more formal mental health treatment in their recovery, and they would receive one-to-one counseling as well as individualized therapy. A lot of this is done in group with peer counselors, that is other veterans who have been through similar experiences and come out the other end, which is a very powerful experience for these veterans. During their time, they meet other veterans, develop friendships, get back some hope and direction in their lives. And as I said, a subgroup of these move on to what we call vocational rehab services to begin re-entry into work if that's their goal. And the next slide. Many of these referred really struggle with legal issues in the system. I mentioned the substance use that challenges without a home or without a stable home, a lot of movement across VAs or across states or across islands. And it's not uncommon also to have medical concerns that are significant and unaddressed over several years or decades. And this transportation issue that Ms. Covington mentioned, getting to an appointment can be very difficult when you don't have the resources even for a bus ticket, let alone a car. So difficult situations to solve. Next slide. But I want to give an example of someone that we did solve it with. Sorry, I'm trying to. Sorry, I had to minimize that. So Mike and not his real name. He wanted to protect his confidentiality, but this is absolutely true of an individual that was treated. Mike was referred to the program by inpatient staff on our inpatient psychiatry ward following a hospitalization for suicidal thoughts, auditory hallucinations, and paranoid ideation. He started the program and met with other veterans, met with the advisor, as I described, who helped him choose the classes that were right for him for his specific needs. During his time in the program, he found support, friends, hope, and an opportunity to grow. Classes taught him new skills, including relationship skills, stress skills, symptom coping, medication management, which was important for Mike. After about 6 months in the program, he began helping other veterans adjust to program entry, a natural leader. A few months later, he reconnected with his family and for the first time in 10 years, met his grandchildren for the first time, that re-engagement with family that's so important. He learned to shop for himself, was able to secure stable housing, learned some job skills, and actually secured a part-time job through the VOC rehabilitation services, and had friends that remain in the program to this day. At his request, he discharged himself from the program, having succeeded in his goals, but maintained contact with other veterans and has done very well maintaining contact with his family and independent living. So next slide, which I think is the final slide. Good. So how to access care at the VA. If a veteran's already enrolled in the VA and seeing primary care, they can simply ask their primary care team, hey doc, or hi nurse, I think I'd like to talk to someone about my stress. It doesn't necessarily mean the person has one of these severe conditions that I mentioned. Often it's very helpful just to talk through some things with someone from mental health. We have a call center at that 1-800, sorry, I've got to move this, 1-800-214-1306, and there's an option to speak with someone at all times to access mental health care if you're not already engaged, and they will talk through that enrollment process that I talked about. We think it's important if someone is in crisis that we see them regardless of their enrollment status. We can work all that out later, but we do want to see any veteran who's in crisis and speak to them immediately to get them to the care that they are eligible for if we are not that person to do that. So I'd like to surrender the floor now and thank you for the time.
Hey, thank you so much. That was a wonderful presentation. I did not know about Vital. That's really important. I know we had a conference that we hosted a few years ago, and we had a gentleman come from the mainland who looked into how many people actually successfully used their VA or their GI Bill. And turns out there are a number of people who had some difficulties transitioning. They'd sit in the classroom, and they'd look at the exits, and they didn't feel that safe or comfortable there. And consequently, they just really wasn't tracked. And he put together a veteran-centric course at university in Ohio, and then went around the nation really setting up some great veteran-centric courses and outed some of those other for-profit schools that were enrolling the TBI folks that would never show up, but the school would make money. So glad to hear about Vital. That sounds like a great program. I do have one question for you, if you don't mind.
Sure.
So you covered the Pacific Rim, and in a number of places. I'm sure you get asked this a lot. So I'm going to beat someone to the punch. Philippines. Who oversees the Philippines?
Manila has a small clinic. It's not a full CBOC, but they have mental health care as well as primary care in Manila. And that traditionally has not been under VA Pacific Islands. I believe that's under San Francisco.
Okay.
So, but they do have services there on site and provide that. We do run into a little bit of problems with some of Micronesia, Palau and Truk. Some of these countries where veterans served honorably went back to live with their families. But by law, we're not allowed to provide services there. They would have to come to us in Guam, for example. And that's something that we hope Congress will solve, because we very much like to reach out to that pretty large veteran group that live on the outer islands.
All right. Well, thank you very much, Dr. Masters. Very nice talk. And without further ado, what I'd like to do is transition over to one element that you spoke of that is vital, and that is some of our service members who have not successfully transferred out of the service and become homeless veterans or become homeless in a variety of different ways. I've been involved with Andrew Dahlberg and his homeless veteran task force for, goodness, I don't even know how many years. So gentlemen, you've not been afforded an opportunity to introduce yourselves, who you are and what you do. So if you don't mind, Andy and Brian, would you please introduce yourselves and then go into your shtick here, please?
Sure thing. I'll start. Hi, everybody. My name is Andy Dahlberg. I've been with the VA for a long time, over 30 years. I can't believe it. And I've actually been involved so long in the homeless program. I can remember when they started back in the late 1980s under something called the McKinney Act. And as I will highlight in a minute, these programs have undergone great evolutions into being state-of-the-art programs right now. I also say, I'm proud to say my dad is a 102-year-old veteran who uses VA. I'm married to a veteran, a retired colonel. And I've been just amazed at the different kinds of services that the VA has offered veterans, and I'm proud to work for the VA. And then I'll turn it over to Brian to introduce himself, and then we can start.
Yeah, thank you, Andy. My name is Brian Kelly. I'm a neuropsychologist. I dedicate most of my time, most of my focus is within the homeless program. But I also wear some other hats, like managing our psychological and neuropsychological assessment consults that come through the station. And I'm also highly involved in our psychology internship and residency training programs, both longstanding APA accredited training programs, and I really enjoy supervising up and coming psychologists.
Thank you.
With that, I'll turn it back over to you, Andy.
So we put together a presentation here, and it's going to go very quick. So it's going to be like riding a bicycle through a museum. So if you have some questions, you can also throw them in the chat. I also want to thank Dr. Brown for helping organize this event. He and I have done many of these events through the years. It's been a great experience. And also to add that this is our third that we've done with the VA. We did one for Guam and Saipan several months ago, and recently did one in American Samoa. So it's great to be part of this. So if you could move the slide forward there. Just to give folks an idea as to how our program has evolved and grown and changed over time. I came into this program in 2010. There was a total of 5 staff. We now have 85 staff that are spread throughout the Pacific Islands. We have a wide range of professionals, staff, mostly clinical social workers, but we also are lucky to have a psychologist like Brian, housing specialists, occupational therapists, and even 3 nurses. And also something called peer specialists, where we have hired veterans who were formerly homeless, who had some kind of mental health issue, and they complement us in the kinds of services and treatment that we can offer to our vets in an effort to get them off the streets and into different kinds of housing. Next slide. I won't go through the list of all our different programs, but at one time when the homeless program started way back, in the 90s, it was pretty much a residential program. And you can see over time just how these things have evolved. And each of these programs has specific criteria and staff that run them. So it's an amazing thing how the VA has rolled these programs out. And you don't think of innovation when you come to homeless people. With the VA, that's what they've done. These programs are very innovative, and the private sector actually copies things that we do. Next slide. Our first program we're going to talk about is something called Grant Per Diem. Basically, it's a short-term housing program where somebody can spend up to 2 years, and we have 4 different tracks. And our program here is located out at Barbers Point and is run by an organization called US Vets. Next slide, please. We also have worked very closely with the site there, where we have something called an enhanced use lease project, where we were actually able to lease this site out to an agency to run it. And at that site, we have a total of over 30 staff that are there, that are in residence and provide services to the community. In addition, the landlord, who is also a developer, recently completed a new building that has 50 units on it. And they have 4 other buildings planned over the next 8 years that they're going to be building, for a total of about 260 more residential units. So we're excited about the future that we have down at Barbers Point. Next slide, please. And HUDVash, Brian, over to you.
Yeah, thanks, Andy. So HUDVash is our largest program within the homeless program. That's an acronym which stands for Housing and Urban Development and VA Supportive Housing. There's a total of 1,060 vouchers allocated to our HUDVash program. Dedicated, I'll tell you more about that in the next slide, but it's really dedicated to, finding stable housing situations for our veterans through a supported voucher. So we have 878 total vouchers for the state of Hawaii. For Oahu specifically, the vouchers are divided between the city and county of Honolulu and the Hawaii Public Housing Authority. 116 vouchers are allocated for our neighbor islands, and we have 66 vouchers on Guam. So the nuts and bolts of HUDVash is to provide intensive case management services for all the veterans that are enrolled in this program. These case managers are really assisting, supporting veterans along the way through their journey from typically an unsheltered homeless situation to, again, securing permanent supportive housing. Our providers are really well trained to serve as a liaison and a communication between the HUDVash program and, again, the Public Housing Authority in Hawaii, as well as the city and county of Honolulu, the Section 8 programs there. So as I said, HUDVash is our largest program. There's 62 team members now across the 4 major islands of Hawaii, as well as Guam. And the team is certainly multidisciplinary. There's specialists you can see here, peer specialists, which Andy had spoken to, employment specialists, housing specialists, nurses, occupational therapists, substance use disorder counselors, social workers, and program support assistants. So it's a dynamic program. And here's sort of a lay of the land in terms of the staff that comprises HUDVash. Another program I'll speak to briefly is called Emergency Housing. And again, this program offers intensive case management as well as emergency housing to help veterans transition from typically living on the streets or coming from institutions to finding stable housing situations. So as far as the outreach piece, all the providers are clinically trained and have expertise in locating, identifying where our veterans are in a houseless situation, and then working to procure, them to find stable housing and to connect them with a range of services that Dr. Masters and that Andy has spoken to. So these include, connecting folks with medical care, mental health services, substance use treatment, emergency housing, permanent supportive housing with HUDVash, and offering that case management all along the way to ensure that our veterans are moving into safe environments and having stable living arrangements. And I'll also mention the locations in terms of emergency housing. We currently have 13 locations with the Institute for Human Services, Kalihi Valley, IHS, Medical Respite at Tutu Burts. We now have 3 locations, 2 in Honolulu and 1 in Kailua. And we also have US Vets out at Barbers Point and the Waianae Shelter, the Civic Center, US Vets. We have a Pearl City senior housing facility, as well as facilities for emergency housing on Maui, Kauai, Kona, and Guam, with a total of 73 beds. And then the final program that I'll speak to briefly is called HPACT, which is an acronym for the Homeless Patient Aligned Care Team. And that's essentially a variation of a typical setup for primary care and mental health services for a veteran that's dedicated specifically to working with our homeless veteran population. You'll see there, it's community-based. So I think what stands out for HPACT is that we go out into the community to provide care for primary care and mental health services. And I think that's sort of the take-home point about a distinguishing feature that makes HPACT really a successful program, is that we're quite versatile in that way. So we're traveling all over the Leeward Coast, Central Oahu, North Shore, and we also spend time in town as well. And the objectives are to reduce barriers to care. So we make, getting access to care quite easy by going directly to where the veterans are located on the island. And we work as a team. We try to provide one-stop wraparound services together that's integrated, and we provide intensive case management and also high quality, evidence-based and culturally sensitive care within the HPACT program. So with that, I will turn it back over to you, Andrew.
Great, thank you. And thank you for also mentioning your outreach work. There's so many aspects of our program where we are basically a program without walls. We go to where the veterans are. We go to where the needs are. This is demonstrated in this one program, Veterans Justice Outreach, where we actually have staff that go to jails and prisons, and they work with vets who have 6 months or less until they're going to be discharged to help them transition and to provide case management. We also just got a new position on Guam. So we're actually spread pretty equally throughout the Pacific Island. We also have something called a Veterans Treatment Court, where we develop mentors within that court to work with our veterans who have justice-related issues. And there is some incredible national rate of, it's like a 90% success rate. So it means that people don't commit other crimes and then go back to prisons. Next slide, please. We also have a program called Supportive Services for Veterans and Families, and I need to update this slide. Recently, these three agencies were awarded almost $5 million to provide services for vets and their families. And I do have a phone number. If anybody's interested in those services here on Oahu, they can call Catholic Charities at 808-521-4351. Next slide, please. We also work closely with our local continuum of cares. And we have something set up which is called a by name list, where we actually know the names of people, of our veterans that are homeless, where they typically are located. And when we identify them, we put them in this system where we try to push them to the top so they can get services immediately and we can get those folks off the street. That's something that the VA, as a best practice, helped introduce into this island about 5 years ago. Next slide. And as Dr. Brown mentioned, we have a homeless task force that has been meeting, I can't believe it, since 2014, which is chaired by Dr. John Henry Felix, who is a veteran himself and also a CEO of a medical assurance company here called HMAA. Pre-COVID, we were meeting live once a month. We're now meeting monthly on Zoom. And it's basically just a great way to network, and it's kind of a local brain trust to think through this problem. Next slide, please. And also, I kind of mentioned that we're part of the Mayor's Challenge, and we have groups that meet and go over this by name list and other relevant data. And it's amazing the progress that we have made since that time. And I know that we've housed well over 1,000 people since that time for Oahu. And then next slide, please. And maybe that's it. I guess that's it. Yeah. So thank you, everybody.
Well, good stuff.
Yeah,
That's
thank you.
presentation. And I know we did have a question come up, but it looked like Dr. Masters already answered that. So yeah, Dr. John Henry Felix, like Miss Covington's father and like Willie Mays, is a Korean War vet. So, all right. I think we've covered some really good stuff. I mean, what we're looking at is those individuals who leave active duty service, the family members, the children of them. Where do they get care when they get out and about? You know, we've got a wonderful VA program here throughout the Pacific Islands. We have community partners. We highlighted one of those partners. Miss Jackie, Miss Boland, I'm kind of running on here a little bit just to see if we get any questions.
Sure,
So,
no problem. Well, thanks everybody for your presentations. If you're watching, if you have any questions, you can submit those through the Q&A. Meanwhile, I just want to remind everybody that we do have a presentation next week with Jessica Lynch, former POW, 7/27 at 4:30 p.m. Same link that you used today. We hope you will join us. And meanwhile, just want to thank everybody here for putting their time and talent into putting this presentation together. We did show it live on Facebook, and we'll continue to be posting that throughout the weekend and let you know how that does. It doesn't look like we have any questions. So with that, I believe we're done.